For our CTACS, CTSQC quality lecture, we're very fortunate to have Patton to share with us his ideas about the challenges of improving surgical quality. Pat is the Director of Surgical Services for the Henry Ford System in Detroit, is the Vice Chair of Surgery there, and has held positions as the Head of Acute Care Surgery and Director of Trauma at the Henry Ford, one of the country's busiest hospitals. He's a graduate of the University of Louisville School of Medicine, completed his surgical training at Henry Ford Hospital, and his fellowship in trauma and critical care at the University of Tennessee. Of course, he's a fellow of the college. He's past chair, COT chair for the state of Michigan, and MSQIP surgeon champion, as well as an associate professor of surgery at Wayne State University School of Medicine. Pat, thanks for sharing your insights with us here in Connecticut.
Good morning. My name's Pat Patton, and I'm the Medical Director of Surgical Services at the Henry Ford Health System in Detroit. It's really an honor to be here with you today, albeit virtual. I wish we could be together and we could be enjoying some nice fall weather in Connecticut. I'd like to thank Dr. Kim Davis for the invitation to speak today. Kim and I had hoped to have some dinner and drinks together, but it's not to be. I hope your experience with the second surge of the pandemic is going better than ours is in Detroit. I'd like to spend a few minutes today talking to you about surgical quality, and without further ado, we'll get started. My talk today is entitled Tackling Surgical QI Challenges, Frameworks and Fundamentals. I have no disclosures. What I'd like to accomplish today is a couple of things. We'll start off by talking about safety science and a system approach to quality and safety. We'll compare and contrast some different approaches you can take to QI challenges. We'll talk about a couple of tools that you can use to help identify system factors at work that contribute to your QI problems. And finally, I'll introduce one of the college's new programs that looks at a system-based approach to quality across what we'll call the house of surgery. A number of years ago, the Institute of Medicine came out with their 6 aspects of quality care. These 6 domains help to inform us about what our goals and plans should be around establishing quality at our organization. A lot of people, sometimes we talk about quality and safety, and those terms sometimes get intermixed. But you can see by this table that safety is but a piece of quality work. The 6 domains identified by the Institute of Medicine include providing safe care, timely care, effective care, efficient care, equitable care, and patient-centered care. Together, these domains form what has become known as the STEEP goals. As we look at these 6 aspects of quality, you'll notice that there are a lot of similarities. The improvement methods and the tools that are used to address problems within these domains are all very similar, and they all focus primarily on identifying problems with the system and trying to get away from a focus on individual activities and placing blame on individuals for errors that may occur. But there are also differences. There can be differences in the objectives that are taken to undertake the work and differences in outcomes that we look for as we proceed down this pathway. This table calls out some of the differences in objectives and outcomes between patient safety projects and other quality projects. In general, patient safety projects look to eliminate, prevent, or reduce harm. These are things like infection reduction, fall prevention, medication errors, etc. The remainder of the 6 aspects focus on really what we've come to know as quality. It looks at adherence to guidelines, best practices, improved efficiency and timeliness. And the outcomes we hope to achieve include things like guideline adherence, waste reduction, and an overall better patient experience. Healthcare has really changed over the last 25 to 30 years. The culture back then was to really focus on individual performance and individual patient outcomes. Things like errors, mistakes, and near misses were rarely discussed. Because of the hierarchy that existed between different roles, such as physicians and nurses and administrators and support staff, there was really a challenge to talk about the way that we approached individual patient outcomes. Thankfully, around that same time, a number of folks got together and started to develop what is now known as safety science. One of those individuals was a psychologist named James Reason. And Reason looked to focus on differentiating between the person and the system, to get away from placing blame on the individual and really focus on what events or factors came into play to set that person up to make that error. And it seems intuitively obvious that no one comes to work to do a bad job or to make a mistake, but we're all human and mistakes do occur. The challenge is not to just accept these mistakes as a given, but to address the factors and the causes that have led to them. This is a busy slide, but it points out one of Reason's major pieces of his work, where he sought to really call out that we should have a blameless culture, and that in fact, most errors that occur, 90% of them perhaps, are really blameless and are due to factors beyond the individual's control. I think this is a really helpful slide, and I would encourage you to take it or something like it and put it in your back pocket or put it on your bulletin board so that you can refer to it often. You can use this algorithm as a step-by-step approach to evaluate issues that may occur in your hospital, to really call out that things really are not the fault of the individual, but are in fact probably due to a lot of system errors that may occur. This slide depicts a number of potential factors that can lead to errors. In healthcare, it's very easy to see the sharp end of this funnel or the sharp end of the spear, where direct patient-provider contact occurs. Errors that occur here are called active errors. What's harder to see and understand are the multiple layers of background that allow these errors to occur. These are sometimes called latent errors or latent failures. These latent failures are a result of organizational design, work conditions, processes, equipment failures, or an overall lack of standardization of process. These factors at the blunt end, so to speak, contribute to or allow failures to occur. When both latent factors and active factors all line up, we get the familiar Swiss cheese model. The key here is to emphasize and recognize the nature and multitude of all the factors involved and really shift the focus from the individual to the system. All errors are likely due to both latent and active factors. Invariably, they occasionally all line up, and this results in a problem. As you start to focus on a system approach to errors, the goal should be to identify where those errors in the system occur. As you do this, you can then identify where changes need to be made. Remember, there are two key objectives. Make it hard for providers to do the wrong thing. And number two, make sure that you have a series of checks and redundancies built in so that you can catch those errors before they happen. To do that, you really need to have a well-informed process and a lot of situational awareness. You've got to really understand your system and what's going on to be successful. So let's now start to dig a little bit deeper into how you gain awareness and understanding of the processes and problems that exist. Most organizations start with their methods for improvement. Here are two examples that are used in a lot of organizations, and both call out that improvement is not a static event. It's an ongoing, continuous cycle of activity. The two most popular cycles of improvement are the Lean Six Sigma DMAIC model. DMAIC stands for define, measure, analyze, improve, and control. The other popular improvement method is the Deming cycle. This is what's known as PDSA or PDCA, stands for plan, do, study, and act. I personally like the DMAIC model as it more clearly defines the activities that are involved and really may help individuals in your organization understand what they need to do. But these are both basically the same processes. Become familiar with these, as they will form the foundation of how you do your improvement work. Nearly all projects can be structured in either one of these two ways, and I would encourage you to use these frequently, even in your most small and minute projects to your big projects. A framework like this will help you keep track of what you need to do and keep moving forward. All right, so where do we get started? Well, you need to identify a problem or an issue. And to do that, you need data. All your quality improvement should be data-driven. Well, what data do you use? There's a ton of it out there. You can use data from NISQIP. You can use administrative data like patient safety indicators or HACS. You can look at Sentinel event reports. You can use your local event reporting system. You can use events that are identified either through your peer review or your M&M process. And finally, you can get unsolicited complaints from either patients or employees. Regardless of which data source you use, you need to make sure that you have it to help you define a problem. In addition, it will also be necessary as you start to make improvements that you can measure what you're trying to change. It's been said that if you can't measure it, you can't fix it. Next on the list of things to do is understanding what resources and partners you have available to help you. No one can do this alone. Not only do you need help with the actual work that needs to be done, you need subject matter expertise to really understand the process. And without getting a broad range of stakeholders involved, you will invariably miss issues that you're unaware of. The complexities of most organizations and processes mean that you will need a broader scope of insights and expertise to learn what you don't know and gain that much needed situational awareness of the problem at hand. These people will help you. Get them involved. Depending on what your specific project is, there's a large group of stakeholders that you'll need to involve, not only to help identify the issues of the problem, but to help you get the problem solved. Once you've gotten the problem identified and the right stakeholders engaged, you'll need to better understand the issue. This will often require a fair amount of background work. To do this, you may need to do chart reviews, deep dives into the data at the patient level, or maybe you'll have to do patient, peer, or team interviews as well to get the information you need to proceed. You'll also need some tools to help assist you to fully understand the issues at hand. I suspect you've used many of these tools on the list, but I'll give you a brief overview of them today to help explain them a little bit better. These things include value stream mapping, fishbone diagramming, root cause analysis, and the use of the 5 whys. You can frequently use all or pieces of a lot of these tools to really hone down and identify your opportunities for improvement. Let's start with value stream mapping. You can make this as easy or as complex as the situation demands. What you basically want to do is draw the flow. Start at the beginning of the process. Identify the main activities in that process. What are the tasks? What are the defects? Call out opportunities that you see for improvement as you come to them. You'll need to make sure that the environment and the stakeholders involved feel engaged. It needs to be a blameless, judgment-free environment. You need to encourage folks to speak up and speak out. Think about what drives each step in the process, or what those influences may be on why people behave the way they do. You can really get creative with a value stream map. You can spend a lot of time on it and you'll gain a lot of helpful insights. The ultimate goal of value stream mapping is to identify and eliminate waste. Waste is something that doesn't add or in fact detracts from the process. In general, the root of all waste is variation. And value stream mapping helps you to identify where and what those pieces of variation are. So you really need to be vigilant as you're putting your process together. Make sure that you've identified all the steps. Value stream mapping really allows your team to get a visual roadmap of the process that they're dealing with. And it helps reinforce that culture of learning and continuous improvement and engagement of stakeholders. The next tool I'd like to talk about is the Ishikawa or fishbone diagram. This is really a cause and effect mapping, and again, helps you visualize what's going on in the process that you're trying to examine. The main problem is drawn as the spine of the fish, and the fins are those causes and contributing factors that lead to the problem at hand. Here's an example of a fishbone diagram that was put together looking at a problem of SSIs. As you can see here, there are causative factors and there are contributing factors. Once you've identified all these factors, you can then focus on areas of particular importance or need. Obviously, you'll never be able to address all these issues, but by doing this exercise, you can identify the things that you may not have considered before and help identify for all the stakeholders where the focus of your work needs to be. Next is the dreaded root cause analysis. Root cause analysis can mean many different things to many people. You can make it as simple or complex as you need to. But basically, root cause analysis helps you understand and identify those latent or hidden factors at the root of the problem. The use and the development of root cause analysis has almost become a science unto itself. Here is kind of a simplified template of what root cause analysis can look like. You look at the antecedent events, some causes, and then there are even root cause classification codes and domains that you can place these things into to better understand the process. Folks who are really into root cause analysis even have specific shapes that signify different events or identify different root causes in the process. Basically, doing root cause analysis is very much like value stream mapping. You track events from the beginning to identify opportunities for change. And using root cause analysis, you can then classify and better understand what factors of your culture or your organization are really at the root of the problem. Here is a simplified example of a root cause analysis that was done for a wrong transfusion event. Again, the actions are recorded temporally as they occur. And as you go along this timeline, you continually ask, why did that occur? Or what caused that to happen in that way? This methodology of questioning then leads to the next tool that I'd like to talk about, the 5 whys. I suspect that many of you in the room, being surgeons, use this methodology perhaps without knowing it every day. We're always asking why. We may not do this formally, but in our daily practice, we always strive to understand processes and disease states even better. Nothing happens without a reason. You just need to dig deep enough to find it. Once you find the problem, you can then identify what changes need to be made to rectify the situation. Always ask why. Why did this occur? So as I've quickly run through a number of these tools, you'll probably notice that they all seem very similar, and they are. But they're not always as easy to use as they may seem, and challenges abound. The biggest challenge, I think, is not knowing what you don't know. You really need to understand what drives behavior and what drives the why of things occurring. Things that can really get in your way are workarounds. Workarounds often cloud the identification of a problem and the evolution of a process. You have to be aware of these and look for them. And finally, you have to understand what drives behavior. Sometimes folks are constrained by resources, or they have demands to become more efficient or rush. You really need to understand why people behave the way they do and what factors in your system is driving that behavior. Once you can understand this, you can have a more successful quality process. All right, so you've identified problems. You've got some tools in your pocket to help you evaluate processes. But how do we reduce the risk of a bad outcome? How do you make change that will really be effective? Obviously, each problem will have its own specific set of solutions, so we can't really talk about specific solutions today, but I'd like to focus on how we should design those solutions so that they're meaningful and they stick. There are some basic principles that you should always keep in mind when you're developing your solutions to problems. First of all, you should always base it on standardization of your care. If you can use evidence-based practices, that's great, but sometimes those don't exist. You should always build in independent checks and redundancies into your system. As I mentioned before, you need to make it hard for folks to do the wrong thing, and you need to make it blatantly evident when a mistake is occurring so that you can catch it before it happens. Finally, we really need to learn how to learn from defects and follow up on the new fixes that we've put in place. This is really hard to do, and probably the one that we do least well in quality improvement. As we look at risk reduction strategies or the fixes to our problems, we can really categorize these into two different domains. There can be weak fixes and strong fixes. A weak solution are things like telling someone to do something differently, telling them to do more education, or making a policy to fix the problem. Strong solutions, on the other hand, involve those so-called forcing factors, the things that make it hard for people to do the wrong thing. This includes examples like putting a hard stop in your electronic medical record. These are much harder to develop, but they certainly have a much stronger staying power than the weak strategies and weak fixes that are very easy to imply. And finally, while you're developing solutions to your problems, don't forget about human factors. Given the opportunity, humans will make mistakes. They will occur. Try to predict these and then prevent them. This is where standardized work and checklists can really make a difference. Ultimately, what you're really trying to achieve is not just solutions that work, but solutions that work all the time. They become reliable. In many ways, this concept of high reliability is the holy grail that many organizations are searching for these days, trying to become a highly reliable organization. What this really means is optimizing both process, culture, and behavior. As the saying goes, bad culture beats good process every day, and culture and people are really hard to change. But if you can do both these things well, you will certainly optimize your patient outcomes in the long run. I came across this word cloud, and I think it really calls out a lot of the challenges that we all face in dealing with quality in healthcare, and particularly in surgery. I'm sure some of the bigger items on this ring true in your experience, things like culture, communication, documentation, implementation, compliance, and herding of cats. They certainly all ring true to me, and I'm sure you'll recognize a lot of these issues that come up as you're developing and working through your quality work at your organization. So to briefly recap what we've talked about in terms of quality improvement, it's all about the system, not the person. Problems are frequently more complex than they seem, and you really need to understand them to identify the defects. You need teamwork and communication to be successful. And this is not an easy task. The journey is long and hard and ever changing, and you're really never done doing quality improvement work. So now for the next few minutes, I'd like to move away from kind of generalized talk about quality improvement and move on to specifically talk about surgery and things we can do in our surgical realm to improve the care of our surgical patients. I really believe, in my opinion, we've got a burning platform at hand here. Surgical care is changing. What we do is becoming more complex. There's higher risks involved. Our patients are older. They have higher acuities. There's a lot more focus on outcomes than there used to be. There's new skills that we need to be successful in practice, things that we didn't learn in medical school or in our residency. Things like project management, change management, leading of teams, etc. There's also financial factors at foot. Fee for service is eventually going to go away. We're all going to need to learn to partner with ourselves, with our hospitals, and really understand the concept of value if we hope to be successful. The American College of Surgeons has recognized this and has tried to put together some resources to help manage these new problems, to help you learn how to really build a surgical quality program that can help you be successful in your practice and ultimately reduce complications, minimize waste, and increase the value for your patients. About 3 years ago, the college published what's become known as the Red Book to help surgeons address issues within quality and safety in their organizations and ultimately help improve patient care. For the rest of the talk, I'd like to focus on some of the concepts that are brought out in the Red Book and how you can use those concepts to improve your practice and really help establish your organization as a leader in the provision of surgical care. The Red Book introduces some principles that may be new to folks, one of which is looking at the surgical experience. As you can see from this cartoon called The House of Surgery, the surgical experience has many factors, many players. It's a complex series of events that affects the patient from the time they hit the physician's office from the community to the time that they've fully recovered and are back to their normal level of productivity. The Red Book breaks down the overall surgical experience into what it calls the 5 phases of care. These are the preoperative evaluation and preparation phase, the immediate preoperative phase, the intraoperative phase, the postoperative phase, and the post-discharge phase. Historically, surgeons have really focused specifically on what happens in the operating room. But as you can see, we now recognize that what happens before the operation and after the operation can oftentimes be just as important as what occurs actually in the OR. Breaking down the surgical experience into the 5 phases of care helps us focus on those areas that we need to improve and gives a framework and structure to our efforts. As you know, the college has a long history of putting together resource documents for things like trauma, cancer, geriatrics. But now this is the first attempt to really look at quality and the whole surgical experience. The Red Book breaks down the standards that it thinks are important into 3 major categories: infrastructure, quality improvement, and clinical care. In all, there are 12 standards that the college thinks are important to develop a high quality, highly reliable surgical program. These standards are listed here, broken down into the 3 domains. They include leadership commitment, culture of patient safety and high reliability, the presence of a surgical quality officer and a surgical quality committee, the utilization of case review, peer review, and utilizing data for surveillance of issues. There must be a continuous quality improvement plan that utilizes data and is data-driven. Programs need to be cognizant and aware of privileging and credentialing strategies at their organizations. There needs to be standardization of process across the 5 phases of care, disease-specific management guidelines and care plans, and finally, compliance with external regulatory metrics and requirements. But just having standards isn't enough. The college wants to use these quality verification standards to be put into action and to really help your organization function. What's depicted here is a Donabedian model for improvement. It looks at domains of structure, process, and outcomes, with the structural framework of leadership that involves the surgical quality officer and the surgical quality committee that utilize our highly reliable culture and rigorous data sources. They form the framework for processes that can occur that include things like case review, peer review, quality projects, and looking at patient care through the 5 phases of the surgical experience. By utilizing this structure and process, we hope to achieve the optimal outcomes of value and high quality of care. But putting together a system like this isn't really easy. While a lot of us currently are on the left-hand side of this slide in our silos, we look at our metrics, we have our processes. Within our own little domain, we're probably doing very well. What's lacking here, though, is integration. How do we work together with our administrative colleagues, with our nursing colleagues, with other departments in our organization to really focus on how we can work together and what we can do to integrate our practice and make it most successful for the patient who's having that experience. The ultimate goal, we hope, is depicted in this org chart, which may be very similar, but maybe not exact to what you have at your organization. You have a hospital CEO, a hospital CMO and COO. You've got various surgical departments that report up to those folks. But what's new on this slide is putting the surgical quality officer and the surgical quality committee in the middle of this. It's the college's hope that this individual and these committees can help lead to this integration across what we're calling the house of surgery, to really build an integrated problem that starts to deal with the problems that we all face in a unified fashion. A framework such as this calls on surgeons to lead the provision of surgical care at their organization. I would encourage you to get a copy of the Red Book, look through it, and I think it will be helpful. Try out some of the things that are suggested. If you like what you see and you think your organization is ready, you can request a verification visit. But before you do that, I'd like you to ask yourselves a few questions before you leave today. Do you ensure appropriateness of surgical care at your institution? Do you perform data-driven PI? Do you employ a standard model for improvement, DMAIC or PDSA? Do you do preoperative risk assessment? Do you optimize patients before surgery? Do you have an organizational structure that supports the surgical experience, that integrates the necessary processes of surgical care? Do you have a surgical quality leader or a surgical quality officer at the center of how surgical encounters are driven at your institution? Do you have a process for case review and provider peer review? Case review is very important for helping us identify issues. And do you have a surgical QI work plan? This is very important. Not a lot of organizations do this. Do you use ERAS and clinical practice guidelines in your delivery of care on a daily basis? These are all questions that we need to ask ourselves. If the answers to all these questions are yes, then you might be ready for verification. Call the college. It's a great feather in your cap to have that designation. If not, we'll go to work. Use the quality improvement tools that we've talked about today. Use your data to drive performance and measure success, and get surgeons in your organization in leadership roles so they can help to drive and improve the surgical experience on a day-to-day basis. I'd like to thank you for your time today. I hope we have some opportunity for some live question and answers at the end of this talk. I hope you have a great weekend. Please stay safe. And thank you again very much.